First of all, I thank all the organizers to calling me here to just present something which does not have much results. So a lot of questions will be there. Thank you, Ajay, for giving the spoiler alert. I'll only be presenting what the study comprises of. So it's just a thought process.
Ladies and gentlemen, you are
It's just a thought process. Mostly, I think so. I'll have a lot of questions. So the thought process here is we have a TKI, we have EGFR mutant 790M negative NSCLC harboring metamplification mutations. So the idea here is, as Dr. Amit earlier told, mutations, mostly resistance due to mutations which come are the most common ones are two, which we earlier heard. The first one was MET only. So this is just a simple, no rocket science application. We just add Capmatinib to it.
An alarm has been activated.
The thing is, we are comparing the driver mutation things to a chemo schedule here right now. So that's the odd thing here. So let's proceed further. So in keeping with this concept and philosophy, all of us are here, I believe.
Ladies and gentlemen, your attention please. An alarm has been activated. We are investigating the cause.
Apparently, I am not being liked by Marriott, so many alarms. Thank you. So this is Southeast Asian population being studied in here. We have Korean people studying it. We have the Chinese people involving it. And as well, the Japanese are being involved into this. So Capmatinib plus osimertinib versus platinumpermetrexed double chemotherapy as second line in patients with stage 3-4 EGFR mutated T790M negative non-small cell lung cancer harboring a metamplification. So nothing too complex, very simple. I'll just go through the next 5 slides. So the idea behind this, MET amplifications can arise as a bypass resistance mechanism. Around nearly 25% of EGFR TKI resistant EGFR mutant non-small cell lung cancers do harbor that. And these patients have limited treatment options. That's what triggers the idea behind such a study. So particularly the EGFR T790M negative arm. Capmatinib, again, all of us know, a MET inhibitor, is approved in about 10 countries for the treatment of metastatic MET exon 14 skipping NSCLC and for amplifications as well. So the geometry trial proved beyond doubt that it has got a good OS benefit. So this trial, they've labeled it as Geometry E. So it is a randomized, controlled, open-label, multi-center phase 3 study evaluating the efficacy and safety of Capmatinib plus osimertinib versus platinum-pembrexed doublet chemotherapy, a second-line treatment. The methods, it's an ongoing study, started in September 2021, still ongoing. The first result will come by December 30. So patients with stage 3B, 3C, stage 4 EGFR mutant, again, I'm repeating the same first line. So these people progressed on either the first or second generation EGFR TKIs, osimertinib or any other third generation EGFR TKIs for that matter. Now, symptomatic neurological meds were not included, bottom line. Patients with neurologically unstable, symptomatic CNS meds, or those requiring increased dose of steroids, less than 2 weeks prior to entry, were ineligible for this study. So it was a 2-part study. The part 1 was mostly focusing on a small number and just focusing on the drug and its effects and the doses. The part 2, elaborately doing other things. So the initial run had 10 patients, which confirmed the recommended dose of the randomized part 2. Evaluate the safety and tolerability of Capmatinib plus osimertinib. And in this, patients received 400 mg of oral Capmatinib, 80 mg of osimertinib daily in 21-day cycles. The part 2, efficacy and safety of this combo versus the chemo. Around 225 patients in different centers, 2:1 randomization, stratified the presence of brain mets. These brain mets were asymptomatic, not the symptomatic ones. Prior treatment with third generation EGFR TKIs, whether it's there or not, again a clause. So the primary endpoint of part 1 was the incidence of dose-limiting toxicities during the first 21 days of treatment. Secondary, again, all statistics, whether the pharmacokinetics are fine, investigator-assessed overall response rate, duration of response, response to time to response, disease control rate and progression-free survival as per the RECIST 1.1. The part 2, as I told, 255 patients, primary endpoint, blinded independent review committee assessed PFS. Again, ORR by BIRC as per RECIST, and overall intracranial response rate. As I told earlier, asymptomatic meds were included. Again, the RA and OBM. Other secondary endpoints, again the same, duration of response, time to response, and disease control rate. This is investigator assessed PFS also to be taken into account. The results of this study are yet to be published. So the reason why this study was put up was basically we have two papers on individual case reports who showed a partial response to this combination, which triggered this study to be conducted. The results are yet to be published, so this case is an open discussion thing. I believe it's a good thought process. No rocket science involved, we're just adding a Capmatinib to met escalations. And any questions, please, most welcome.